Chapter 59, Concepts of Care for Clients with Diabetes Mellitus. The priority concept in this chapter is glucose regulation. The interrelated concepts in this chapter are nutrition, tissue integrity, sensory perception, immunity, fluid and electrolyte balance, and acid-base balance. For glucose regulation, we have a process of maintaining optimum glucose levels in our bodies. With diabetes mellitus, that is known as sugar diabetes. This is going to be a chronic endocrine disorder of impaired glucose metabolism. And as you know, glucose in our bodies is the main source of fuel. We have to have glucose in order to live. So with diabetes, we either have an absence of insulin or its action. Lack of insulin comes from lack of production, or there is a problem with the insulin use at the cell receptor. Here are some of the signs and symptoms of diabetes mellitus, and we call these the 3 Ps. So we have polyphagia, polydipsia, and polyuria. So it's really important to know what each of these means. So polyphagia, they're really hungry. Polydipsia, very thirsty. And polyuria, lots of urine. So again, we have a problem when the body either does not produce enough insulin or when the cells are resistant to the insulin. When this occurs, the body turns to the breakdown of fatty acids as its source of energy. This releases ketone bodies and can lead to ketoacidosis. Dehydration with diabetes mellitus leads to hemoconcentration, hypovolemia, hyperviscosity, hypoperfusion, and hypoxia. This results in acidosis that triggers the brain to increase the rate and depth of respirations in order to blow off CO2. And that's what we call Kussmaul respirations. Chronic complications of diabetes includes macrovascular and microvascular disease, retinopathy, nephropathy, and neuropathy. Cardiovascular disease is generally going to be associated with the diabetes mellitus clients who are obese, have hypertension, hyperlipidemia, and a sedentary lifestyle. Risk of stroke is 2 to 4 times higher, and also risk of poor stroke outcomes. Elevated glucose levels at the time of the attack may lead to greater brain injury and a higher mortality rate. For eye and vision problems, legal blindness is 25 times more likely in clients with diabetes mellitus. The longer the client suffers with diabetes, the more likely they are to have diabetic retinopathy. Almost all clients with diabetes have some sort of diabetic retinopathy after 20 years. Diabetic peripheral neuropathy is progressive deterioration of nerve function, and this can involve all parts of the body. There is damage to the sensory nerves. It starts off as pain and it progresses to numbness, and damage to the motor neurons results in muscle weakness. This is caused by blood vessel changes and decreased tissue perfusion. Diabetic nephropathy is a pathological change to the kidneys that leads to dysfunction and ultimately to failure. Diabetes mellitus is the leading cause of kidney disease in the United States. Kidney disease progresses from a loss of albumin from declining glomerular filtration compounded by hypertension. Sexual dysfunction can happen in both men and women, but is more likely in men, and this is related to damage to the nerve and vascular tissue. Cognitive dysfunctions can occur with clients who are over the age of 65, and that's due to chronic microvascular disease that contributes to neuron damage, brain atrophy, and cognitive impairment. Metabolic syndrome is also called syndrome X. This is classified as a presence of multiple different factors known to increase the risk for developing type 2 diabetes. So I kind of think of it almost as a pre-diabetic state. So it increases your risk for type 2 diabetes and cardiovascular disease. The symptoms of this are going to be your abdominal obesity, hyperglycemia, and that's your fasting blood sugar of 100 or more, and hypertension as well. So they'll have a systolic blood pressure that's elevated, as well as a diastolic, and high cholesterol or your hyperlipidemia. So clients with metabolic syndrome are going to be at an increase of type 2 diabetes and cardiovascular disease, atherosclerosis, coronary artery disease, early death, stroke, a lot of different things. So the focus on here is education and prevention of developing type 2 diabetes and cardiovascular disease. So with diabetes, we're looking at two different types. Type 1 is an autoimmune disorder in which the body destroys the beta cells of the pancreas that produce insulin. Clients with type 1 diabetes are going to require exogenous insulin. Type 2 is a progressive disorder in which clients start out with insulin resistant that progresses to decreased secretion of insulin from the beta cells. This can be controlled with diet, oral hyperglycemics such as metformin, and glucophage, and they may eventually end up needing insulin as well. It's very important to note the differences between these two types of diabetes, the causes of them, such as, for example, with type 1, sometimes this is caused by illness. So it's important to differentiate between the two. Genetics do play a factor in type 2, but there are also some modifiable risk factors here. Going back to this just for 1 minute, also look over the signs and symptoms of this. So like your clinical manifestations with this, a lot of times they're pretty close, but there's a few things that are notably different. Like typically with type 1, they experience weight loss, and typically with type 2, there is weight gain prior to diagnosis. For health promotion and maintenance, we want to control blood sugars to avoid complications. So that's going to be a major focus, is going to be education. We can't cure type 1, but we can control the effects that it will have on the body. And really the same thing with type 2. There's not a cure for it. Once a client is diagnosed with that, that is a diagnosis that will stay with them for the rest of their life. But with proper glycemic control, we can get those clients off insulin, the type 2 ones. We can get them off insulin and their oral medications, potentially. Okay, so for interprofessional care, again, the focus is going to be on education. We want to educate the clients on how to check their blood sugar. So a couple different ways to do this. We have a fasting plasma glucose, and that can be used to diagnose diabetes mellitus in non-pregnant adults. And this involves having two separate tests that result in a blood sugar of 126 or greater. This one is performed first thing in the morning. So fasting plasma glucose, first thing in the morning, or if they work night shift, before their first meal. So they have to be fasting. Oral glucose tolerance test. This one, the OGTT, is often used to diagnose gestational diabetes and is not generally used as a diagnostic otherwise. So with levels of greater than 200, we have a provisional diagnosis of gestational diabetes. Hemoglobin A1C, or glycated hemoglobin. That is a standard test that is used to measure how much glucose is permanently attached to the hemoglobin molecule. A normal range is going to be less than 6.5. Anything over that is a diagnostic for the presence of diabetes mellitus. This test is often used to determine how compliant a client is with their diabetic treatment. The higher the number, the longer the client has been exposed to elevated blood sugar levels, signaling uncontrolled diabetes. And this is a very good indicator of how they have been trending over the past 3 months. Because remember, an average red blood cell lives for 120 days. So once that sugar attaches to that hemoglobin molecule, it is there until that cell lyses or breaks down. So with clients that have excellent glycemic control, that A1C is going to be close to normal range or possibly within normal range. But if they've not been compliant with their diabetic regimen, it's going to be elevated. Screening for diabetes with an A1C is generally going to be recommended for clients over 45, people that are obese or have other risk factors such as genetics. Random glucose testing is just what it says. It's at a random time, so the client doesn't have to be fasting. Typically, they're going to be elevated, but there's a lot of reasons why somebody would want to do a random. Say they had signs and symptoms of hyper or hypoglycemia, and you want to check and see where your client, what your client's blood sugar is. So you would do a random. And we kind of already talked about screening. Ongoing assessments, I spoke to that as well. So we do an A1C typically every 6 months to a year, depending on how your client is doing, to determine compliance and how the client is doing with their current regimen. But we also want to check other things like their kidney function. We want to do a CBC, check for their albumin as well, urine tests. So we're going to be checking a lot of different factors. And there's some really good charts on diabetes in your textbook that will help you. So priority collaboration for clients with diabetes include potential for injury, impaired wound healing, diabetic neuropathy, kidney disease, hypoglycemia, diabetic ketoacidosis, and hyperglycemic hyperosmolar state, and coma. So if you think about it, a lot of these are going to tie together, especially when you're talking about peripheral neuropathy. So many times these clients are unaware that they may have developed an injury on their feet because of the numbness. So a lot of times this goes untreated, and this increases the risk for infection, which coupled with poor circulation and hyperviscous blood, the risk of foot ulcers and injuries are pretty significant with them. And also the risk of necrosis increases. This is a major cause of amputation with diabetic clients. A lot of times when I have a client that has a planned amputation, like not due to trauma, like it's planned because of injury, a lot of times those clients have a history of diabetes with a foot injury. So education is going to be crucial with these clients. They want to wear good fitting shoes. So we don't want them to go barefoot, because a lot of times if they step on things, they can't feel it. Or if their shoes don't fit properly, they could get a blister. So they want good fitting shoes, preferably leather, something that is going to protect their feet. And then after they're done washing their feet, they need to inspect them, make sure that their feet are dry all the way before putting on socks and shoes. And again, there's a lot of great information in your textbook on diabetic foot care. There is a potential for diabetic ketoacidosis, or DKA, and that is characterized by uncontrolled hyperglycemia, and that's a blood sugar of greater than 300. And if you remember when we were discussing metabolic acidosis, we have an increased production of ketones, and that can cause that fruity acetone breath. So a lot of times with these clients, I kind of feel like it smells like Fruit Loops. And that usually occurs with type 1 diabetes, but it can also occur with type 2. The hyperglycemia is going to lead to osmotic diuresis, dehydration, and electrolyte loss. They can also have abdominal pain, confusion, weakness, shock, and they can go into a coma. It is very important to manage diabetic ketoacidosis and metabolic acidosis overall because it is life-threatening. Treatment is going to involve fluid replacement, starting with normal saline initially. Drug treatment is going to involve insulin. It's usually going to be IV. For IV treatment of insulin, those clients either need to be in an ICU setting or a PCU setting, depending on the hospital policy. And with this type of treatment, you want to start the insulin slowly. So there's going to be a lot of finger sticks with this. Sometimes it's every 15 minutes. It's always nice if they have an ART line in so you can draw their blood off that instead of sticking their finger all the time. Sometimes if it's severe, these clients may need some sodium bicarbonate. And mild to moderate hyperkalemia is common with DKA. So the insulin therapy is going to help with that as well, because that's going to help carry the potassium back into the cells. Correction of acidosis and fluid volume replacement can help lower the potassium level initially, but frequently this can also lead to hypokalemia. So sometimes with these clients, potassium replacement is usually needed as serum levels fall below 5, because after that they tend to fall very rapidly. So the key to that is going to be frequent monitoring. When their glucose levels fall below 250, IV fluids are then going to be switched to D5.5 normal saline, and that helps prevent hypoglycemia and reduces the risk of developing cerebral edema, because we don't want to treat this too rapidly, especially if they're in a hyperosmolar state. So again, and I can't stress this enough, I'm going to say it a couple more times, education is going to be key because we want to prevent injury from hyperglycemia. A lot of different medication options here. Oral medications such as metformin, glucophage. And the glucophage itself doesn't increase insulin secretion. What it does is it's going to decrease liver production of glucose and decreases intestinal absorption of glucose. So that's going to increase the insulin sensitivity in the body, and it allows it to enter back into the cells. These can lead to lactic acidosis in clients with renal disease. And if you remember back in fluid and electrolytes, we talked about this with things like metformin. We must hold those drugs 48 hours before and after contrast because it's really toxic to the kidneys. There's also sulfonylureas like your glyburide, your glimepiride, your glipizide, and these are going to trigger the release of insulin. There's also insulin sensitizers such as Avandia and Actos. Those are going to increase cellular utilization of glucose. The precaution here with these is they cannot be used with clients with cardiovascular disease or congestive heart failure because it increases the risk of heart-related deaths. And again, for medication therapies, make sure that you are checking out the charts that are in your textbook because there's a lot of good information in there. So insulin therapy, there's a lot of different options here. We have rapid acting such as Lispro. That's going to be one of the more common ones. The onset for that is usually about 15 to 20 minutes, and it peaks at 1 to 3 hours and lasts for about 3 to 5 hours. Short acting, that's going to be your regular and your Humulin R. The onset is going to be about 30 minutes, peaks in about 2 to 5 hours, and lasts for 5 to 12. And that really depends on the brand because the Humulin R can last for up to 24 hours. Intermediate, that is going to be like your NPH and your 70-30. NPH has an onset of about an hour and a half, and it peaks in 4 to 14. And again, that depends on the brand and lasts for 16 to 24. 70-30 has an onset in about 15 to 30 minutes, peaks in 2 to 4 hours, and lasts for 24 hours. So as a side note, with insulin, you always need to be aware of your peak times because that is when your client's going to be at the greatest risk for hypoglycemia, is when the insulin is working at its best. Then we have long-acting. That's going to be your Lantus or your Levemir, and the onset of that's going to be 2 to 4 hours. And your peak really depends on the brand. Some of them do not have a peak, but these are going to be insulins that last for about 24 hours. And again, there's a really nice chart in your textbook for information regarding insulins. So teaching is going to be huge with these. It's going to start at diagnosis. We don't want to wait till discharge because we want to make sure that the client knows how to check their blood sugar and how to drop their insulin. So typically what I do, even if I know the patient's been diabetic forever, I go in the room and I ask them, do you check your blood sugar at home? If they don't, I ask them, are you supposed to? Like, are you supposed to check it? And if they say yes, like they've been diabetic for a while, and I ask them why they don't, it's really important to, and I know we don't ask why because it's not therapeutic, but I always kind of try to probe a little bit more, because what if they don't have the equipment or can't afford their testing supplies? So there's a lot of things we can do there for them. So make sure you're asking. And then typically what I do is I check their blood sugar and I show them how to do it. And then I tell them the next time you're going to check it on your own with our equipment, of course, because we have to. And then the same thing with drawing up their insulin. I'm going to show them how to do it once. And the next time I want them to participate in it because I want to make sure that they're safe once they go home. So make sure you're teaching them about injecting. We commonly go into the belly. It's the easiest place for the client to administer their own insulin. But sub-Q is key. So you can also go to the back of the arm. So if you're going in the abdomen, just make sure you're more than 2 inches away from the navel, and that way they can have some fast absorption. And then we want to teach them about rotating the sites, and that is to prevent lipodystrophy. And that's very important, preventing lipodystrophy, because once that happens, that site will no longer have reliable absorption of insulin. So sometimes you'll see that happen with clients that keep injecting in that one spot over and over again. They'll end up developing lipodystrophy, and then their blood sugars are all over the place because maybe that area of their body will no longer absorb properly. We also want to make sure that we're teaching them about the signs and symptoms of hyper and hypoglycemia, because with insulin especially, we can have instances of hypoglycemia. We want to teach the patient about not taking too much insulin if they're not eating. So if they're not getting a whole lot of nutrition in, we want to educate them on that. And also for sick days. Sometimes these clients won't eat when they're sick, and they'll suffer from severe hyperglycemia. So we want to teach them to check their blood sugar frequently. We want to let them know when to call the doctor, when to call 911, and how to treat hypoglycemia. So we want to teach them to recognize it, and not just them, but their family as well. So we want to make sure that, family, friends know to look for signs of irritability, dizziness, confusion. Diaphoresis is going to be a huge one, and that they can check their blood sugar and then treat it accordingly. Insulin storage, it should be stored in the refrigerator to prevent bacterial growth. Different brands of insulin have different storage recommendations as to how long they can be left out of the refrigerator. So teach them that they should be looking at the box insert for more information, because if they're taking it with them to work or school, etc., they may not have access to a refrigerator. Make sure that you teach them how to inspect the vials before they draw up their insulin, so they're looking for irregularities. I've seen some types of insulin that maybe have not been stored properly, and they'll have crystals in them or discoloration, and we don't want them to use that. For syringes, we want the clients to use the single-use insulin syringes. They're marked in units, not in mils. And that's if they use syringes. I prefer the pens personally because they're a lot easier to tell how many units, and it's a lot easier for the clients to use them. Blood glucose monitoring, they're going to receive a monitor and some test strips. So the American Diabetes Association does a lot of donating with these so they can get a free meter. So the meters are pretty cheap. It's the test strips that are expensive. And those do require a prescription. So they can't just walk in and get those. They require prescription. And the monitoring is going to depend on what the provider has indicated, but the ADA, the Americans with Diabetes Association, recommends 3 or more times. So sometimes they'll say before meals and at bedtime. Sometimes they'll say just 1 time a day. So everybody's different. And you want to make sure that they know how to use that meter. So I always have them show me, can you show me how to use this meter? Infection control measures. So they're going to clean the site. I make sure that they have like a whole box of alcohol wipes when they go home. That way they can clean that site. And that includes before they stick their finger for their blood glucose monitoring and before they inject themselves with insulin. So it's not just about rotating the site. It's about making sure it's clean. Make sure their hands are washed and don't share equipment. Diet therapy, and this is going to be my opinion here. So my opinion is anybody that has diabetes mellitus should be seeing a dietitian and an endocrinologist. It doesn't always work out that way, but I always request it. So diet therapy is going to include a reduced caloric intake, avoid empty calories such as white rice, white bread. Those are both low in nutrients, and we want to increase veggies and whole grains. Good fats like avocados, nuts, olive oil. Those are all good fats. And that's really going to help them achieve good glycemic control. Avoid alcohol. Alcohol has a lot of sugar in it and carbs. Carb counting, that can sometimes be used to determine insulin coverage. And the orders would be very specific for that. It would tell you, and it's different for every client. It might be 1 unit for every 15 gram of carbs. It might be 2. It just depends on how insulin resistant your client is. But I tell them to keep a food diary. And again, there's a lot of good information in your textbook about client education with all of this. But this is going to be the biggest component for clients with diabetes. You're going to spend the most amount of your time with that client educating them. If you have a facility, work in a really good facility that has a diabetic educator, ask the provider to have that diabetic educator come in and talk to that client as well. But really, we should be around the clock educating them. Okay, come in their room. It's time for to check your blood sugar, and just every single time you're in there with everything you do. And this concludes Chapter 59, Concepts of Care for Clients with Diabetes Mellitus.